I'm Dr. Michael Brumage. I'm the Executive Director for the Kanawha-Charleston Health Department and Assistant Dean for Public Health Practice and Service at the WVU School of Public Health. I'm going to be talking to you today in this webinar about adverse childhood experiences in West Virginia and why it matters. And I would ask you to take a look at this first slide to kind of frame what I'm talking about and reflect on what it would take with the picture of an infant on the left side of the screen in the unlimited human potential that I think most of us would agree an infant has, and in 2 short decades end up with somebody on the right who is homeless, sleeping on a park bench, perhaps with substance use or mental health disorders. And just reflect on what kind of things have to happen to get from the left side of your screen to the right side of the screen. And that's what we're going to be dealing with this webinar. Our learning objectives today are to describe the connection between adverse childhood experiences, or ACEs, and diseases in adulthood, to recognize the 10 ACEs categories, demonstrate the social consequences of ACEs in economic terms, discuss the frequency of ACEs in West Virginia, and describe the connection between ACEs and the opioid epidemic, which is on all of our minds these days. So the Adverse Childhood Experiences Study or the ACE study, was maybe the most important study, which most Americans are unaware. It was a large epidemiologic study done with over 17,000 beneficiaries of Kaiser Permanente in Southern California. And one of the main messages from this is what's unrecognized in the pediatric exam room shows up in the internal medicine exam room decades later. And that's a really interesting concept, to think that what happens during our childhood has lifelong effects. And when we're talking about the ACE score in the original study, what we're talking about are 10 categories of childhood abuse and neglect. And what we're talking about specifically are 3 categories of abuse: emotional, physical, and sexual abuse, emotional or physical neglect, and 5 categories of household dysfunction. Specifically, 1 or both biological parents missing from the household, domestic violence, and specifically toward the mother. It does not include domestic violence towards the father, mental illness in the household, substance use in the household, and incarcerated member in the household. So if you want to think about it like this, everybody has an ACE score between 0 and 10. 0 being having none of those categories, and 10 having all 10 categories. This only measures whether you have once in any one particular category. So, for example, if there was a history of childhood physical abuse that happened multiple times, that would still only count as a 1, so that everybody has a score between 0 and 10, as I said. And you can delve deeper into the ACE study by going on to the link at the bottom of this slide on the CDC's website. In fact, if you just Google up ACEs and CDC, you'll come directly to this website. There are over 50 published studies that can be found, and you can go in great depth on the CDC website. The reason that this is really relevant is that the ACE scores are really linked to physical and mental health problems later in life. So that compared with people with no ACEs, those with 4 or more ACEs were twice as likely to smoke, twice as likely to have cancer or heart disease, 6 times more likely to be depressed, 6 times more likely to have had sex before age 15, 7 times more likely to be alcoholics, 10 times more likely to inject drugs, and 12 times more likely to have attempted suicide. So there's very strong linkage with people with high ACE scores. And men with a ACE score of 6 or more were 46 times more likely to have injected drugs than men with no history of adverse childhood experiences. Not 46% more, but 46 times more. So this is a very strong linkage between things that happen in childhood that are adverse and diseases and mental illness as an adult. I'm going to go through these next few slides rather rapidly, and what you're going to see in each one of these slides is a graded response between ACE score and the outcome that we're going to be talking about. In this slide, it's specifically around a lifetime history of depression. And the other thing that you'll notice is not only the graded response between ACE score and a percent who are depressed, but also that women are more likely to be affected by ACE score than men. And you'll see that this is pretty consistent across all categories, and when we're looking at the summary data in a later slide. This slide is showing you the correlation between ACE score and prevalence of attempted suicide, almost exponential. This one is from the original ACE study showing the correlation between ACEs experiences and current smoking. And you can see another graded response that continues to rise as the number of ACEs increases. And this one is of particular interest to me around the opioid epidemic and around substance use. This is the correlation between ACE score and drug abuse in 3 categories: ever had a drug problem, ever addicted to drugs, and ever injected drugs. And you can see, very similar to the previous slides, that a score of 5 or more really puts you at much greater risk, so that the percentage of those with that particular problem is drastically increased relative to those who had 0 or a lesser score. Now, ACEs does not only show up in the clinical setting, it also shows up on the workplace. And here in this slide, you can see a correlation between ACE score and absenteeism, ACE score and serious financial problems, and serious job problems. So you may know of people who you work with on a daily basis with whom you have problems related to the workplace, or they're frequently absent, and the likelihood is very strong that there's an ACE score associated with that. We are all paying for this as well. This slide demonstrates the economic burden from a study by Fang and a group. The lifetime costs associated with maltreatment have been estimated between $210,000 and $1.8 million per child, and that's when considering associated health, behavioral health, education impairments, increased involvement in the criminal justice system, child welfare, social welfare, and lost work productivity. So this is a tremendous economic burden which we are all paying. Not only that, but it affects those who have been afflicted by early childhood toxicity in terms of reduced annual earnings. This is in 2009 dollars. This is also from Fang, from the original, the previous slide, showing that child maltreatment on average has a reduction in annual earnings of almost $6,000, which is the same as obesity, teen pregnancy, and smoking combined. So this has a profound effect on the pocketbooks of people who have been affected by adverse childhood experiences. In a recently reported study from the National Survey of Children's Health in 2016, they looked at ACEs in children across the United States. And this map represents, if you look at the state rankings, you'll see the different patterns of the states in terms of whether they were lower than the U.S. average or significantly higher. And you can see that West Virginia in this map is significantly higher than the U.S. average when looking at adverse childhood experiences. Nationwide, the percent of children between ages of 0 and 17 with 1 or more adverse childhood experiences in the United States was 46.3%, and that range went from 38% up to almost 56%. The state with the highest percent of children 0 to 17 with 1 or more adverse childhood experiences was Arkansas. But you can see that West Virginia, Kentucky are 2 of the Appalachian states with a percentage significantly higher than the U.S. as a whole. Now, I want to bring to your attention that this particular survey was a little bit different than the original 10 ACE score that we talked about with abuse, neglect, and household dysfunction. Many of these are the same and you'll recognize it. So I put that on the right side of the screen. So they're looking at 9 different categories in this National Survey of Children's Health. So one that's different is somewhat often or very often hard to get by on income, different. Parent or guardian divorced or separated, that's the same. Parent or guardian died, that's a little bit different. Parent or guardian served time in jail is the same as in the original A study. Saw or heard violence in the home, similar to what we have from the original 10 original 10 categories. Victim of violence or witnessed neighborhood violence is definitely different than the original A score. Live with anyone mentally ill, suicidal, or depressed is the same. Live with anyone with alcohol or drug problem is the same. And this is also a different category, often treated or judged unfairly due to race and or ethnicity. And the citation for this is at the bottom of the map. Now, you might be thinking, okay, we're talking here about adverse childhood experiences, but there's also the things that are happening external to the home of origin. And that's why I like this concept of a pair of ACEs. And this tree diagram really represents that very well. So the top part of the tree, the part above the ground, is adverse childhood experiences, the original 10 categories you can see clustered around the outside of the tree. But at the root of the problem, and you can see this widely spread out root pattern, are adverse community environments, the other ACE. And specifically here we're talking about poverty, discrimination, community disruption, lack of opportunity, economic mobility, social capital, poor housing quality and affordability, and violence in the neighborhood. So you can think of this in two ways. Things that are happening behind the front door, which are the adverse childhood experiences, and things happening beyond the front porch, which are the adverse community environments. And the citation for this work is at the bottom of the slide. If you go on to the CDC's website, you'll see on the left-hand side there is a pyramid, and there's a bold black line at the base of the pyramid with an arrow going upward from conception here, as you can see, all the way up to death. And so what we're talking about, we start out at the bottom of the pyramid with adverse childhood experiences, which then leads to social, emotional, and cognitive impairment. That then leads to the adoption of health risk behaviors. Then you have disease, disability, and social problems, and the top of the pyramid ends with early death. You'll see on the right-hand side there are a couple of arrows that indicate, and I'm trying to point them out now, scientific gaps, and we have a much better understanding of why this happens. So people who experience these traumatic events in childhood end up having changes in their brain and changes in their body due to the hypothalamic pituitary adrenal axis. We even know, in fact, that this affects the chromosomes at the level of the telomeres, which are the caps at the ends of the chromosomes. And when those caps get shorter, as they do with toxic stress, that presages cell senescence and death. So that at even a subcellular level, these adverse childhood experiences are having profound effects in the brains, the bodies, and even at the subcellular level, which of course then leads to social, emotional, cognitive impairment and adoption of health risk behaviors. And this is an interesting point because many of these health risk behaviors that we identify as problems are actually attempts at solutions for these social, emotional, cognitive impairments. So that's a really unique way to think about this as it's happening. People are trying to deal with the stress from childhood in ways that include smoking. Is there a benefit to smoking a cigarette? Well, we know that nicotine is a psychoactive drug and that there is probably a benefit from taking a puff from a cigarette. It has long-term deleterious consequences, but in the moment that you're doing it, it actually provides some sense of relief. And so it also then helps us understand that when we ask somebody to quit a behavior, such as smoking or drinking or the use of drugs or whatever the drug of choice might happen to be, that it's difficult to do that unless we replace that with something else. So it makes it understandable then why it becomes so difficult. Of course, there are changes in the brain, but we also have to consider that we are asking somebody to give up a coping mechanism when we ask them to stop some of these health risk behaviors. We know that, for example, smoking and drinking leads to problems with lung disease, heart disease, liver disease, and there you see the next step up in the pyramid, and some of these end up with early death from all those diseases or cancer. Now on the right side you see a similar pyramid, and I won't go through the common parts of it where we start at this base of conception, which I'm trying to draw a line to right now. But beneath of the base, preconception, you have trauma and social location, which leads to more problems. So we have generational embodiment over historical trauma. And if we want to think of for just a moment about the historical trauma that's happened to different groups who are living in the United States today, you may consider African Americans who were brought over as slaves and have that historical trauma. You may want to consider about Native Americans who were displaced from their land, or even people who came later to the United States, Holocaust survivors who are experiencing historical trauma. Above that are the social conditions and local contexts that you might find in inner city neighborhoods, or for example, in the case of Appalachia, the coal fields and some of the smaller towns in the coal fields of Appalachia. And on the right-hand side, you see three things listed: microaggressions, which are things that people who are being discriminated against experience on a daily basis that we may not be aware of if we are in the predominant group, which is white Americans in West Virginia. Implicit bias in epigenetics. So we used to think that there was nature versus nurture. Nature was our gene inheritance, and nurture was the environment around us, the pair of ACEs that I've just spoken about. But now we understand that the line between nature and nurture is not quite so clean. Epigenetics helps explain that. We are all born with sets of genes that can be either turned on or turned off. And if we are exposed to certain stressors, we can turn on or off certain genes, which are then inherited by our children and can be passed on for generations. So that the old biblical saying, the sins of the father are inherited by the sons, this is actually true in that what our genetic changes can be inherited by our children. So it's a very interesting way to look at the ACEs pyramid and the historical trauma embodiment element. One of the major problems that we're having today in West Virginia and across the United States is the opioid and heroin epidemic, the opioid crisis. And we know there's a strong correlation between adverse childhood experiences and the opioid heroin use in the United States. In 1998, the original ACE study done at Kaiser Permanente that I spoke about at the beginning found that those who had an ACE score of 3 or more had a much greater likelihood of engaging in substance abuse, domestic violence, and suicidal attempts. In addition, were more likely to be obese, have dropped out of school, and to be divorced and have diabetes, cancer, and heart disease, with the ACE score of 6 or more, with a 4,600% more likely, or 46 times more likely to use intravenous drugs relative to those with an ACE score of 0. In 2016, another study found that people with this ACE score of 5 or more were 3 times more likely to misuse prescription pain medication and 5 times more likely to engage in injection drug use. Another 2009 study found that over 80% of patients seeking treatment for opioid addiction had at least one form of childhood trauma, with almost 2/3 reporting having witnessed violence in childhood. And the references for all 3 of those studies are listed below those bullets that you can see on your slide. At the Kanawha-Charleston Health Department in 2015, we wanted to see how prevalent adverse childhood experiences were in our community. So we did a survey that we distributed via the press, and it was published in newspaper, television, radio, and the web, and through email. And we used a SurveyMonkey tool, which was a web-based tool. And this was not in any way designed to be a full community cross-section or a scientific study, but merely to open a discussion on the role of ACEs on our major public health problems. by taking a quick snapshot and discussing the results with our community. But I think it's worth showing the results because they were interesting nonetheless, because a large number of people responded. One of the things I wanted to make sure that we remember is that there's the relevance of ACEs to public health problems and what it means and what it does not mean. And the way I think about ACEs, and the way I think everybody should think about ACEs, is that it's a risk factor. It is not a predetermining factor. And I kind of compare it a little bit with a cholesterol score. So, for example, we know there are people with a low cholesterol level who end up getting heart attacks or cardiovascular disease. Likewise, at the other end of the spectrum, we know there are people with very high cholesterols who never have a heart attack or cardiovascular disease. But on a population basis, we understand that there is a correlation between cholesterol or lipids and cardiovascular disease. So I wanted to make sure that people understood that drug and alcohol problems can happen in families with an ACE score of 0. So we absolutely did not want to stigmatize, blame, or shame the parents for these issues. But understanding that this is a population level connection and that it represents a risk factor. So in this slide, which shows a map of West Virginia, you can see the results from the KCHD, Kanawha-Charleston Health Department informal survey. And what was remarkable is that we had 506 respondents. And that was from the majority of counties across the state of West Virginia. So when you look at the map, you can see both colors and numbers. The red counties, which are in the center of the state with 252, Kanawha County, Putnam County, and Cabell County are the ones with the highest number of respondents, as was Monongalia County in north central West Virginia, and 10 people responded from Ohio County. Any county that you see on this map with green had at least one respondent, and if they had more than one, I put the number in that county. So you can see the vast majority were represented. Interestingly enough, we had respondents from 6 other states that you can see in the bottom right that I won't read out to you. So again, 506 respondents, 76% were female, so it is not a population representative survey. 95% were white, 1.6 African American, 1.4 Native American, and 1.2% Asian or Pacific Islander, which is consistent with the population of West Virginia as a whole. We are a predominantly white state in West Virginia. Now I'm going to talk you through this table slowly because these are summary statistics. On the left column, you'll see the number of adverse childhood experiences, 0, 1, 2, 3, and 4 or more. Then you see a column with women and men. You can see that women are disproportionately affected relative to the men with higher ACE scores. And then you see the summary between men and women under the column called total, where you see that 36.1% had an ACE score of 0, which means that the majority of people in this original study had a score of 1 or more, and 12.5%, or roughly 1 in 8, had a score of 4 or more. So that's the benchmark, the original Adverse Childhood Experiences study. On the far right, you see a column that says KCHD, which was our survey results. And in our survey, we found that roughly 28% had a score of 0, again meaning that the vast majority of people had a score of 1 or more. And what was really interesting is under the score of 4 or more, we found that 28.2%, more than twice the landmark Dr. Felitti Kaiser Permanente study had a score of 4 or more. So pretty remarkable that so many people had a higher ACE score than the original study. I'm showing you the cover right now of a book called Hillbilly Elegy, which was a New York Times bestseller by the author J.D. Vance. J.D. Vance talks in this autobiography about his family growing up, and as I was reading the book, it occurred to me thinking about it from the perspective of ACE is that he actually had a very high ACE score in his family of origin. And when I added it all up as I was reading the book, found out that he actually had an ACE score of 6. And what was really remarkable is that in the last chapter of his book, J.D. Vance talks about the ACE study, grades himself out as a 6, and grades his family out with their ACE score as well, to reveal that most of them had a very high ACE score. And so he relates his experience with adverse childhood experiences to things that happened to him later in life. So to complete the story, though, J.D. Vance did not end up with a lot of long-term adverse consequences as an adult. In fact, he went off to join the Marines, and when he came back, went to Ohio State University, graduated a year and a half early, summa cum laude from Ohio State, went to Yale Law School, where he became editor at the Yale Law Review, one of the preeminent law journals in the United States, and became an attorney for an investment bank in Silicon Valley. Recently, in the last year or so, J.D. Vance moved to Columbus, Ohio, to give back to where he came from. But nonetheless, this is a striking example in the popular literature how you can find how ACE has affected people. It turns out in this book that J.D. Vance's mother became a heroin addict. J.D. Vance was exposed to many men coming in and out of the house with his mother as he was growing up, but his mother sank deeper and deeper into mental illness and substance use. So very interesting and very relevant to what we see here in Appalachia today. It's a good book if you ever choose to read it. It's controversial, you may or may not like it, but nonetheless relevant to the discussion around adverse childhood experiences. Of particular interest, again, is how ACEs is relevant in the discussion of the opioid epidemic that we have in West Virginia. At the Kanawha-Charleston Health Department, we have probably the largest harm reduction clinic, which includes syringe service program, syringe exchange, in all of Appalachia, and maybe one of the largest in rural America. So I wanted to ask our patients as they came in about their ACE scores and compare it with the original Kaiser Permanente study. So in this table, you see on the left-hand side ACE categories with abuse, neglect, and dysfunction in all the separate categories. I've blocked out men and women so that the numbers won't be so confusing. But then you'll see the total says over 17,000, and below that there are numbers. Those are percentages as you go down the column. So that, for example, you can see that when I follow the cursor here, 9.9% of people reported physical neglect in the original study. We asked almost 200 patients in the harm reduction clinic, our syringe service program, the same 10 ACE categories, and these are the percentages that we got. And you can see that what's really remarkable is that the numbers with physical abuse and sexual abuse were nearly the same, but in every other category it was between 1.5 and 3 times what it was in the original Kaiser Permanente study. When you look at the last category at the bottom of the chart, you'll see incarcerated household member, 4.7% in the original study, 28% in our group of patients that we asked in our syringe service program. So this is pretty remarkable. And now we're going back to another chart that you saw earlier. You'll recognize this from the original adverse childhood experiences study, but in the last column, in lieu of the Kanawha-Charleston Health Department's survey, you'll see the survey that we did among those 199 patients from our harm reduction clinic. And you'll see that a couple of really remarkable things from this chart. You'll notice that 33.7% of the patients had a score of 0, which means that adverse childhood experiences in a third, roughly, were not at play. But when you look at the column, the row with 4 or more, 12.5% in the original study, 39.2% in the syringe service program, suggesting that a lot of the patients who are coming in who are using injection drugs may be doing so related to things that happened to them from childhood, that they've experienced a tremendous amount of suffering relative to the baseline population. So really pretty striking results and food for thought when considering the opioid epidemic. On this slide, I'm showing you 8 West Virginia public defender cases to demonstrate the correlation between our criminal justice system and ACE score. And on the left-hand side, you see that there are 8 different clients. The summary of their age, gender, race, education, prior felony, and current offense are all listed on the slide, which I will not read to you. But if you look at the last column where it says ACE score, you'll see that only 2 of the 8 had a score of 1. Nobody has a score of 0. But then you'll see 2 people with a score of 8, 2 people with a score of 7, 1 person with a score of 9, and 1 with a score of 4. So this is showing up in our criminal justice system not only with the things that are happening around the opioid epidemic in our state. So what do we do about adverse childhood experiences? The first thing is to acknowledge that the problem exists and then to ask the questions. Frequently, providers will not ask the questions, and this is really nothing more than a quantitative social history. And this is often, in a busy clinic, one of the first things to go. So we need to find time to ask the problem, and it could change actually the treatment or the testing that a provider does. We also need to educate the public and our decision makers in the law enforcement and justice systems about adverse childhood experiences and how this is playing such a prominent role in West Virginia. Then identifying the families that are at risk. We can provide primary prevention programs to treat traumatized people before they become parents and to break that intergenerational cycle at the maternal-paternal child level. If we believe the science around ACEs, this very strong evidence, then we also then have to recognize that by interrupting this intergenerational cycle where ACEs gets passed on from generation to generation, we have an opportunity, a tremendous opportunity, in fact, to do something that will change the outcomes of children. But at the same time, we have to attend to the suffering of the parents. Teaching better parenting skills and cultivating resilience is another thing that we can do to address ACEs. But there's other literature, which I did not address in my presentation today, that suggests that the role of providers makes a profound difference, such that when you discuss this with parents or you discuss it with patients, they are not only receptive, but it changes the way they parent and then they appreciate providers asking about it. In conclusion, we're really changing the question of what's wrong with a person to what's happened to the person. So think about that for just a moment. When we ask somebody, what's wrong with you? Or we ask each other, what's wrong with that person? That's a fundamentally different question than what happened to that person. And that provides an opening for compassion, for understanding that we can change the way we think about substance use in our communities. This helps us address stigma around mental illness, stigma around substance use, when we frame it in the way of what's happened to the person. We need more research to find out the best mechanisms to ask about adverse childhood experiences and other sensitive questions. And we know that our primary prevention efforts will succeed when we begin asking the correct questions. So frequently we rely on, specifically around the opioid epidemic, approaches like just say no or simple psychoeducational approaches. But when we dig deeper and we begin asking the right questions, we'll come up with fundamentally different primary prevention efforts. So that concludes the webinar for today. I hope this has been interesting for you, given you some food for thought, and hopefully provoke some more questions. If you'd like to find out more information, you can go not only to the CDC's website, But if you Google NPR and adverse childhood experiences, you'll come to a very good website where you can take the ACE questionnaire yourself, and the website will tell you what it does and does not mean. And if you want a very quick synopsis of Dr. Felitti, one of the original co-investigators of this study, speaking about adverse childhood experiences, Google up Big Think and Felitti, F-E-L-I-T-T-I. It's about an 8-minute video, very educational, and I think you'll appreciate watching it. Thank you for listening to this webinar today, and good luck.